Let's continue on our talk then about the cardiovascular system. I think we all are familiar that the heart is actually 4 separate chambers. The 2 atria are separated by a intra-atrial septum, and there's the interventricular septum separating the 2 ventricles. The heart is encased in a sac called the pericardium, of which it has a couple different portions, an outer wall that is very thick and fibrous, and the inner wall of the pericardium that is on the thin side. There's portion of it is the parietal surface, portion is the visceral purpose, similar to the pleura. And then we know about the 3 layers of the heart, the epicardium, myocardium, and endocardium. That should all be reviewed. Here's what a heart looks like. Kind of an ugly looking thing. And the way it's positioned in the body is such that it's on a little bit of a twist. So the right ventricle is what is the most anterior portion of. This is showing some of the blood vessels that are involved as far as perfusing or draining the heart. Oops. Yeah. This. Let me go back here. This is the anterior view, and this is the posterior view. And we'll spend a lot of time the last semester going through not only rhythm recognition as far as ECG, but 12-lead interpretation. So you can look at a 12-lead EKG and know at what portion of the heart there is damage, which vessel is feeding that portion of the heart, and how we would go about treating that. The primary arteries that I want you to know, as far as the coronary arteries, the left circumflex, which basically comes and wraps around the heart. You can show it real well there. It's coming around, wrapping around the back. The left anterior descending, which is basically coming down and feeding primarily the left ventricle, but also the septal portion. And the right coronary artery, which feeds the right side of the heart, as well as the posterior wall. So if you notice, there's a couple different spots where multiple arteries feed, and that's good because if you didn't have that, what we call collateral circulation, if there was an occlusion in one point, you would end up having it. If I were to look, where'd they go? I think I'll just draw it on here so you can see it on the video. So if this pen, good. If this is my heart, don't you love my drawings of my heart there? Coronary arteries, the primary ones are the left anterior descending, the circumflex, which wraps around, and again the right, which is feeding the right side of the heart. Okay. If you think of the heart as a box, it's really multiple surfaces for it. This part right here is the anterior, lateral, inferior, septal, and the back posterior. There's no, and what I'm speaking about specifically is the left ventricle. When we talk about patients having heart attacks, it's the left side that we're focused primarily on. Can you have a right ventricular problem? Absolutely. Are they as common? No, it's the left ventricle that's the problem. And specifically, these blood vessels then feed different surfaces of the heart in the process. Okay. And you can imagine that if I have an obstruction here, it's not as bad as if I have an obstruction here, because there's less mass of muscle that is involved. Okay. This, by the way, is what we call the widowmaker, because it's right feeding pretty much everything. Yeah.
So the left circumflex and the anterior descending come off of the left coronary artery?
That is correct. And it's a pretty quick branch right after they leaves the aorta. The coronary arteries really only perfuse the muscle during diastole. If you think about it, if a muscle is contracting, it can't absorb blood. It's got to only in its resting state. Same is true, by the way, with the diaphragm. It's only perfused during exhalation. During the inhalation where it's contracting, it's not being perfused.
You said the coronary artery is...
I probably lied. Go ahead.
Is only used mainly during...
The heart muscle itself
Yes.
is only perfused during diastole.
Okay.
So when the heart is not contracting is when the blood flow from the coronary arteries goes into the muscle itself.
Okay.
And we'll find it, well, back up here. 5% roughly of cardiac output goes to the heart muscle itself, which doesn't sound like a lot, but overall it is. We'll find that the amount of oxygen the heart uses is huge compared to the other organs of the body. It's a pig. And it takes up space in the thorax, so the lungs can't be as big. I mean, like, really? We need this stupid thing? Yeah, we do. Here's another drawing. You can see the anterior descending in the circumflex as well as the right coronary artery. What you can't quite see is where these two are joined back behind the pulmonary artery there. Here's probably a better view of it. Here's my left coronary artery branching off of the aorta, right coronary artery. It then branches into the circumflex and the anterior descending. Okay? And this is the aortic valve, and you can see here the two coronary arteries been dissected across, but there's immediately after that valve is where the coronary arteries are. So they're getting some of the best perfusion, the highest pressured flow that you could possibly have, because it's right after the aortic valve. Once the blood is used, then, it's drained through what are called the great cardiac veins, or the middle cardiac vein. And I don't think you really need to worry too much, just that they're both dumped into the coronary sinus, which dumps into the right atrium. So blood from the heart that's used, it's deoxygenated, is dumped into the right coronary artery. Is dumped into the right atrium. Sorry. There is, however, a small portion of the blood which dumps into the left atrium. And if you think about it, that's like taking used blood and putting it in, mixing it in with good blood that's coming back from the lungs. We're going to call this an anatomic shunt. Shunt meaning that I am going from the right side to the left side without going through the lungs. Does that make sense? Yeah, let me say it again. It's called a shunt. And it's blood that's basically venous blood mixing in with arterialized blood. And there's some portions of the body where this occurs. One of the ones that is associated with the heart is the Thebesian veins. Thebesian veins are veins which dump blood that's been used by the heart into the left atrium, where the left atrium normally has good, well-oxygenated blood coming back from the lungs. Into the left atrium. So it's venous blood mixing with arterial blood, which then means what? The PO2 is going to be a little bit lower. If I have a PO2 of 40 mixing in with a PO2 of 100, mix them together, that's going to drop that down a little bit. Did that just make sense, or did I just lose you? Okay, good. So here's the, you can see them dumping into the coronary sinus and into the right atrium. although it doesn't show the Sabesian veins, but there is one there also. Blood flow through the heart you should be well versed with, starting in the right atrium, passing through the tricuspid valve into the right ventricle. From the right ventricle, it then moves through the pulmonary semilunar valve or pulmonic valve into the pulmonary arteries, goes to the lungs, pulmonary arteries, pulmonary arterioles, pulmonary capillaries, pulmonary venules, pulmonary veins, back to the left atrium through the bicuspid valve or mitral valve. I always hate that it gives two different names for it, and I inevitably, which valves are open during diastole, the bicuspid and the mitral? No, stupid, that's the same valve. But anyways, passes through that, goes to the left ventricle, pumps out through the aortic valve and through to the aorta, to the systemic circulation. You have to do that for A&P, right? Track a drop of blood, moves, yeah. This is just a website that has stuff on the heart. I'm not going to go there for now. We know the cardiac valves, a couple of things about them. First of all, during diastole, you end up having blood moving from the atrium to the ventricles. So the tricuspid and the bicuspid valves are the two that are open. During systole, when the heart muscle contracts, a couple of things happen. First of all, the two semilunar valves, the aortic and pulmonic, both open. The two other valves, the tricuspid and the bicuspid, are held closed by contraction of the papillary muscles, pulling the chordae tendineae and therefore holding the valves closed, because the natural tendency of that valve would be to flop open. When we do have situations where we have that valve being incompetent, that's where we end up developing things like murmurs, okay? Where blood is leaking back retrograde back into the atria from the ventricles. Did Jeannie or Ray get to heart sounds yet? Okay. Once the blood then leaves the aorta, again, the coronary arteries are located immediately after the branch or the aortic valve. The ascending aorta then branches into three vessels: the brachiocephalic, the left common carotid, left subclavian, and it then continues on down to the descending aorta. The brachiocephalic then branches into the right subclavian and right internal carotid, or right common carotid artery. That's a horrible slide, isn't it? You can't really see it that well on the screen, but you got it on your page, so it's okay. And you've had all this before, right? Is it really? Maybe I should probably find it a better drawing. Is it? Oh, okay. We're going to consider the pulmonary system, beginning with the as it leaves the right ventricle through the pulmonary semilunar valve, and continuing through till it gets back in the left atrium. Systemic system, beginning with the left ventricle and continuing back till it gets to the right atrium in the process. And this is kind of a diagram of diagrammatic representation. It's a picture of what I'm talking about. So this is all considered the pulmonary system, going to the lungs and into the systemic circulation being the other portion that you end up having there. No, that's not what it looks at. This is all venous blood. That's what it's all deoxygenated blood. For right now, we won't worry too much about all the various pressures that exist. We'll come back and visit that next module. But you can see the mean aortic pressure is a whole lot higher than what you're seeing at the capillary systemically, and ultimately what's higher in the right atrium. We know that the arterioles are our resistance vessels. We know that the veins are our capacitance vessels. The vast majority of the blood that is circulating through your body is located somewhere in the veins. This is just diagramming the artery on top. You know that there's much thicker walled vessels. Actually, has 3 different levels: tunica adventitia, tunica media, tunica intima. And in the case of the arterioles, they're actually that elastic tissue and smooth muscle are what are regulating blood pressure. Looking at the veins on the bottom, the big key part is that there are valves there to prevent retrograde flow. So it only goes in one direction. And then after the arterioles, before you get to the capillaries, there are small sphincters which are present, which regulate blood flow to the individual capillaries. So, for instance, if there is a need to shut down blood flow for whatever reason, those sphincters can control that. 3 different pressures that you should be aware of related to blood flow through a vessel. One, there's a pressure inside, or what we'll call intravascular or intraluminal pressure, the pressure here. There's a transmural pressure, which is the pressure across the wall. So the pressure outside versus the pressure inside. We can also talk about there being a driving pressure that moves the blood in some direction. No pressure differential, no blood flow. Same as airflow. Has to have a difference between a high and a low pressure. Where's the highest pressure in the systemic circulation? No. Systemic circulation, where's your highest pressure? Yeah, in the aorta. Where's your lowest? I'm sorry? How about if I even go one better and go right atrium? Because they both dump into there. This is roughly somewhere on the order of 2 to 6 millimeters of mercury. This is, on average, if we do look at it, somewhere about 80 to 90 millimeters of mercury. Huge, huge difference. That's why you get the blood flow through the systemic circulations, because of this driving pressure that you end up having. Where's the highest pressure in the pulmonary system? Okay, how about the pulmonary artery? Right after the pulmonic valve. Where's the lowest? Left atrium. Pardon me? Left atrium? The end of the pulmonary process. You don't need to know the numbers yet. We'll get to that later. But just recognize that there's a pressure differential that exists between the highest point in that circuit and the lowest point in that circuit. Is that a fair deal? Okay. Also notice that the pressure differentials between the two systems is profoundly different. Very high pressure difference in the systemic circulation, very low in the pulmonary circulation. Much, much easier to perfuse the pulmonary vasculature than it is the systemic. Which is why the left ventricle is so much more muscular than the right ventricle. Right ventricle is a little, wimpy thing, but it doesn't have to generate a lot of pressure under normal conditions. How am I doing? This is all A&P review, yes, more or less, kind of, sort of. Okay. So again, we can talk about a pressure within the vessel itself, that's intravascular or intraluminal. We can talk about a pressure difference between the inside of the vessel and the outside, transmural, and we talk about a driving pressure pushing blood flow through the capillary or through whatever. No, just more terminology.
What is the transmural pressure on that then?
I'm sorry?
What is the transmural pressure on that then?
The difference between what is in the pulmonary capillary and what is in the alveolus. It's something external to the vessel itself.
So it's the same on that side?
I'm sorry, say again?
Plus 15 on that side and inside. Plus 15 would be equal.
It's a difference of 15 here, 15, 0, 10, 0, 5, 0. So the transmural pressure changes as the different pressures change. So I know that there has to be a drop going from the left side to the right side, otherwise blood wouldn't flow. Assuming alveolar pressure doesn't change, that transmural pressure is going to drop as you go across it. Okay, so intravascular, transmural, driving. And this is just kind of showing, at least as far as the systemic circulation is concerned, going from the aorta, dropping down to the vena cava, and ultimately into the right atrium. There's a huge pressure drop that exists because of that huge driving force. And we'll come back and visit that another day. But it's a cascade downward. We know that arterial blood pressure is basically, in theory at least, the same throughout the body. It's really not. If you take blood pressures at different portions of your body, and they should be a little bit different, but roughly our normal blood pressure is somewhere between 120 systolic, 80 diastolic. And we're going to introduce a concept called mean blood pressure in a second, because of course there's got to be a formula for calculating that. But because I have a systolic and a diastolic, it's kind of hard to compare two different pressures with the right atrium, which only has one pressure. There's not an alteration between systole and diastole in the right atrium. Technically there is, but it's so small we don't talk about it. The concept of pulse pressure is just basically the systolic minus the diastolic pressure. And that's called pulse pressure. So if I gave you a blood pressure of, let's say, 110/70, what's my pulse pressure? That's a hard one. Okay. But there is the concept of pulse pressure. And basically, the larger the, well, yeah, we'll just leave it there. Now, this is one I can guarantee you will see. Whoop. Well, something you may want to pay attention to. The mean arterial pressure is the systolic plus the quantity twice the diastolic, all divided by 3. If you think about it, I don't know if this is truly true, but you spend twice as much time in diastole as you do in systole. So if I want to know what the average pressure is, I have to account for both of those times. So if my blood pressure was 120/80, 120 plus twice that 80 divided by 3, or 280 divided by 3, or 93.3. How do I determine what the mean is? Well, 140 plus twice 60 divided by 3. 140 plus 120 divided by 3, 260 divided by 3. I don't know what that works out to. Yeah, 87. Okay. Okay. We measure blood pressure through a a blood pressure cuff attached to a meter, a sphygmomanometer. We also can measure blood pressure, at least in the intensive care units, by placing a catheter into the artery, and therefore we can not only monitor blood pressure continuously, we also can draw blood work off of there and be able to not have to poke the patient each time. Okay. Pulmonary system, there actually is a mechanism, and we'll talk about this extensively in Module F, where we can actually float a catheter into the pulmonary artery and monitor the pulmonary artery pressure. Just like the systemic blood pressure, it has a diastolic and a systolic. Normal value is roughly 25/8. And because we have a systolic and a diastolic, we can calculate a mean pulmonary artery pressure. And if you'll notice, it's a whole lot less than what is in the systemic circulation. It's a much more compliant system. The control of that blood pressure is accomplished through baroreceptors, which are basically receptors within certain arteries, specifically the carotid and the aortic. They have little sinuses where these receptors are located. And basically they respond when they sense a drop in pressure by sending an impulse back to the brain to say, hey, dude, we got a problem here. We need to do something to raise blood pressure. The carotids in the neck go back via the 9th cranial nerve, which is the glossopharyngeal. The 10th, or vagus nerve, are how the impulses from the aortic baroreceptors get back. Okay. So if I took Ashley and I cut off her leg, and she's bleeding all over the floor, the body would sense the fact that there was a loss of vascular volume, loss of pressure within her systemic circulation. It would send an impulse back. The aortic baroreceptors would send an impulse back via the vagus. The carotid would send back impulse via the glossopharyngeal. And the body would do things like divert blood to places other than her leg. Or it'll shut off blood flow to the kidneys. There's no reason to perfuse kidneys when she's bleeding all over the floor, right? It's going to increase blood flow to the heart, increase blood flow to the brain. Shuts off everything else. It'll also probably increase the heart rate as a compensatory mechanism to be able to manage the blood pressure. Does that make sense? Is that new? Kind of, sort of? Okay.
They work together?
They do. They do.
Back to the pulmonary blood pressure, so like when we get ABGs in the blood class, when they do what they do, put P catheter, like they also put adjustment, is that gonna change the blood?
Oh, totally.
Oh, well?
Oh, my God, yeah.
Oh, so that's why they...
Remember we talked about the normal arterial value is 80 to 100?
Mm-hmm.
What's the normal PVO2? And the pulmonary artery is really the best place to get it because you're getting venous blood from all over the body mixed together. If I draw venous blood from my arm and measure the PO2, it tells me what my arm is doing. It doesn't tell me what the rest of my body's doing as far as what the oxygen use is. If I look at the pulmonary artery, though, oof, that's mixed all blood together. So, yeah, if you see a venous blood, that's typically what it is. It's a PA catheter. Okay. So here's where they're located at. Your carotid sinus are basically in the carotid artery. And you can see the aortic arch has the aortic baroreceptors. Carotids, aortic. And this is different places where you can palpate pulses. I think you're pretty familiar with most of them in the process. The primary ones that we're going to be involved with are the radial, the brachial, and to some extent the femoral, because that's the three spots that we might sample arterial blood from. Okay. You know what? Let's do this. Let's take a few minute break. Okay, let's talk about the conduction system within the heart. If you remember, there's two different types of tissue that are within the heart, one of which is responsible for generating force to pump blood. That's the muscle. There's also a secondary portion, which is electrical. That muscle won't contract unless it's stimulated. So we need to have some sort of electrical stimulation go on, and it does it in such a nice way as far as the rhythmic mechanism. The normal start of that beat is originated in the sinoatrial node, or the SA node, and the SA node is one of the spots within the heart that has what we call automaticity, the ability to begin firing without any other external stimulation. It's like a clock on the inside, a little timer that says, oh, time for a beat, oh, time for a beat, time for a beat, and initiates that conduction through the rest of the heart. Once the impulse passes through this is my sophisticated heart, by the way, okay? So the SA node is located somewhere up in the upper left corner of the right atria. It then passes through some pathways leading to, I should probably do this in a different color. Do it in red because it's the heart, you know.
What is that spot?
This here,
Yeah.
that's your AV node. Atrial ventricular node. Must be between the atrium and the ventricles, and it is. It's kind of where the juncture of the juncture of the two septums, the interatrial and the interventricular septum, as well as the division of the valves themselves. So that's my AV node. It then passes through a structure which is adjacent to that node called the bundle of His. It's His, not his, because we'd have to have a bundle of hers. Just be wrong. Then goes down two bundles, one feeding the right side, one feeding the left. And these are your bundle branches. And ultimately leads into individual fibers innervating the muscle called Purkinje fibers. And I'm guessing Purkinje was somebody who got them named after him, because I don't know where else would come up with a weird name like that. And there's this rhythmic process where once an impulse is initiated by the SA node, it goes on and continues, in a wave-like fashion downward.
So the way you have it set up on a PowerPoint is like the way it actually goes, like step 1, 2, 3, 4, like that?
Yeah. Why?
Okay.
It seems like an odd question. I don't know. Why would I not put them in order? Okay. Well, you should know the order, yes. And it does follow that fashion, yes. 1, 2, 3, 4, 5. I never had that question asked before, but now I have. I didn't say it was stupid, it just was interesting for me. Okay, so here you end up having kind of another diagram of it. One thing that I will tell you, for my purposes and for really a lot of authors' purposes, this bundle of His, this AV node, are just kind of joined together because they really are, in essence, one and the same as far as their purposes in life. So if I refer to the AV bundle, I'm talking about them both together. You can see that once it gets through the bundle, it then goes into the two main bundle branches, which then branch and branch and branch until all the coronary muscle is innervated, yeah.
Why is it going into the left atrium too?
It's got to contract there too, doesn't it?
Well, I mean, like, up there with that, they know.
Once it leaves the SA node, it goes, there's actually multiple paths, as they had little arrows diagramming, where it innervates both the right and the left atrium, as well as passing that impulse through the right atrium to the AV node.
Is this delayed a little bit?
Hold your horses there, young lady. Yes, it is. That's the purpose of the AV bundle. Okay. In fact, let's talk about that right now. The purpose of the AV bundle is to slow the impulse down. It gets innervated from the sinus node. Hold on there, buddy. Hold on. Hold on. Okay, go. Okay. Why? Close. Why do we need a pause between the SA and the AV? Well, actually, you want them to contract pretty much at the same time. You want to allow time for what is being contracted from the atrium to fill the ventricles. I don't know if that's what you were implying, but it's not what I heard. Okay. In other words, if the atrium and the ventricle were contracting at the same time, all that blood that's in the atrium can't get into the ventricle because the mitral and tricuspid valves are closed. So there's a delay that is there. Okay. Once it passes them through, it's a smooth innervation of the entire ventricle. The sinus node can be is innervated by both the vagus, parasympathetic stimulation, as well as the sympathetic stimulation. So the body has the ability to increase or decrease heart rate when necessary. And being chased by the crazy man with the knife, it's sympathetic stimulation, fight or flight. Once everything's relaxed, I can go back and slow the heart rate back down with the parasympathetic stimulation. Kind of a hint. The sinus node has an intrinsic firing rate of 60 to 100. So normal heart rate then, 60 to 100. If the sinus node was damaged, think about this for a second. When I talked about the coronary arteries, the right and left coronary arteries, the left anterior descending, the left circumflex, they not only feed the muscle, some of them also feed this pathway. So for instance, the right coronary artery feeds the right side of the heart, feeds the SA node. So if there's some occlusion of the right coronary artery at the point where it distally would feed this SA node, the SA node, like any other tissue, it's going to die. Well, that's not good for conduction of your heart if you have a part of that electrical conduction system that's dismantled. So the body says, well, you know what, if my SA node doesn't work, Mr. AV node, you're going to have automaticity too, and if you don't get an impulse, you're going to fire at a rate of 40 to 60 per minute. And the heart's smart enough to know, well, if my SA node is damaged and my AV node is damaged, the ventricles themselves can intrinsically fire at something less than 40 beats per minute. Does that make sense?
So it only fires at those rates if the previous one is not working?
You got it. So the ventricle would never fire on its own because it's getting innervated at a faster rate.
More of a backup.
It's a backup. Yeah, go ahead. Go ahead, Ashley.
I didn't hear what she said.
She said the ventricles would never fire at that rate because they're always getting innervated by something above it. And we'll find that there are dysrhythmias that exist when the sinus node goes down and the AV node takes over. And you can identify that the origin of that beat is the sinus node. Or in the case of the ventricle, it's very obvious. There's no, well, it's obvious. How am I doing? SA node fires 60 to 100. If it doesn't fire, AV 40 to 60. If that doesn't work, something less than 40 is where the ventricles, the Purkinje fibers themselves, will self-innervate. We can evaluate this electrical activity, this pathway, by looking at an electrocardiogram. ECG, EKG, whatever. The EKG comes from the fact that there was a German who came up with this cardiogram. Was like, okay. Depolarization is the process of basically the, well, let me just say the process of depolarization is what causes the muscle to contract, generates a systolic blood pressure. That repolarization, the relaxation of the heart, is what results in a diastolic. For right now, I won't get too crazy on this, but you may have seen this from physiology or from A&P, where they were talking about what occurs to create the systolic, the depolarization of a muscle, and it has to do with you have an influx of sodium, an influx of calcium, and a moving out of potassium. If you were to look at the serum sodium and calcium levels in the bloodstream or outside of the muscle tissue itself, that positive charges are higher than what is the positive charge on the inside of the cell. What's on the inside of the cell? Potassium. Sodium and calcium on the outside. There's more sodium and calcium on the outside than there is potassium on the inside, so we say that the inside is relatively negative to the outside. What ends up happening is as sodium moves in, calcium moves in, potassium moves out, now there's an exchange that is there. And now the inside of the cell is more positive than it is negative, and eventually it goes back to the other direction. What do I want you to know about this? Well, there's some movement of some ions. And the charge of the cell changes. Because that cell, because those electrolytes move, I can track that and measure that. And know when systole is happening and know when diastole is happening. Know when a muscle is contracting and when it's relaxing. Whew, that's enough of that. That's painful. This is the important one. I've been doing this a lot today, haven't I? But this goes back to A&P, right? You've had this at some point. All right, there's some different waves that are created due to physiological activity within the heart. As the atria contract, as that sinus node fires, which it automatically will at a rate of 60 to 100, and that impulse begins moving down the atria are in a spot where they're having that transition from sodium and calcium on the outside, potassium on the inside, and it switches. Depolarization. The atrial depolarization is referenced by the P wave. Which is this portion here. Oop. Where it says P. Where it says atrial depolarization. There's then a pause that exists. From the end of the P wave, let me draw a little bit better here, to the beginning of the QRS complex, there's a small pause. That's what the AV node is doing. AV node says, hold on there, buddy, Mr. Impulse. Now go. because it wants to allow time for that contraction of the atria to dump the blood that was in the atria into the ventricle through my tricuspid and bicuspid valves, which are open during diastole. That's a big sentence. Once that impulse then leaves the AV node, it continues on down the bundle branches through the Purkinje fibers. That's depolarization of the ventricle. Once a muscle depolarizes, once it contracts, what does it do next? It relaxes. It repolarizes. That movement of ions goes the opposite direction until we're back to where we started. There's a period of time prior to that happening, and the T wave represents ventricular repolarization. There's a very important point between the two called the ST segment. The ST segment represents the point in time between depolarization of the ventricle and repolarization of the ventricle. And we're going to use that ST segment when we talk about 12-lead interpretation to determine where the site of the damage in the heart is. Is it that inferior wall? Is it the lateral wall? Is it the anterior wall? Blah, 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 blah. P, atrial depolarization. QRS, ventricular depolarization. T wave, ventricular repolarization. Which one didn't I mention? Atrial repolarization. Right? Where's that? Trapped in the QRS. Can't see it. Why do you think that is? No guesses? Who's got more mass, an atria or a ventricle? Well, ventricle, huge more. Much more muscle. So it's going to manifest itself far more pronounced than the little dinky atrium that is there. Susan, how may I help you? No, come on. You know I'm kidding you.
Okay, so the PR interval, is that where the AV node creates cause?
Correct. Correct. Once it passes through the AV node, you start the QRS complex. And continues on until it's done. Go ahead.
Can you say, was the ST segment another pause? What was the ST segment?
Just a pause between the ventricles depolarizing and the ventricles repolarizing. And the ventricle repolarization is represented by the T wave. When you have damage to the muscle tissue itself, the position of that ST segment changes. It gets higher or lower. And for right now, I don't want to go into anything more than that, but it's a very important part of the tracing to watch. Mm-hmm. You can't draw that? Come on. Even I can draw it.
It's easy. I feel like it's easier with that.
I think you need to know which is associated with which. It's not going to be so much a drawing labelless graph. It's going to be what represents ventricular depolarization. P, QRS, or T. For right now, you don't need to know these times, but eventually they will come back to visit us. But there's measurements we can make to see how long the time is between it starts in the atrium and it starts beginning in the ventricle, the PR interval. We can look at the duration of the QRS complex. How long is it taking to get through the ventricle? Because if there's some damage, it's going to take a little longer to get through. And how long till the heart recovers from depolarization through repolarization? For right now, all I want you guys to know are just the intrinsic rates that are present. We said 60 to 100 for the SA, 40 to 60 for the AV, and less than 4, something less than 40 for the ventricles. But this also kind of nicely outlines what each of the function of each of those areas are, as well as where they're located.
You only want to know those 3 values?
Yeah, for right now, I think that's the important thing. You should know. Well, let me back that up. You should know that the SA node is atrial depolarization. AV node is you should be able to correlate what's happening with the ECG tracing with what's going on structurally with the heart. Yeah. But this is actually from the text we use the final semester, which is a little more in depth. Okay. Who's had an EKG done? Guess what? And by the time I think the semester's done, you'll probably be covering that. I think they're one of the last things that they cover in the fall semester. But you'll be doing them on each other, or the PEs you have. When we do a 12-lead EKG, we are measuring that PQRST mechanism from 12 different views. If you think about it, the heart is not a two-dimensional structure, it's three-dimensional. I want to look at it from multiple views. I'm going to look at it from the left, I'm going to look at it from the right, I'm going to look at it from the bottom, I'm going to look at it from the top, I'm going to look at it from the front, look at the back, blah, 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 blah. And I do that by placing leads onto the patient, or placing electrodes onto the patient. There are 10 electrodes that we place onto the patient, and a combination of 2 of those electrodes gives us a lead. I don't know if I said that right or not. But basically what we're looking at is the movement from a positive to a negative. No, I said that wrong. Negative to a positive. Shoot. Sorry. That's going to tell us how we're looking. 3 leads are what we call the standard leads, or limb leads. They're uniquely named lead 1, lead 2, lead 3. That part's easy. There are 3 augmented voltage leads, AVR, AVL, AVF, standing for augmented voltage right, augmented voltage left, augmented voltage foot. And then there are 3 precordial or chest leads called V1 through V6. Now this means nothing to you at this point, so let's give it a little bit of sense. If I were to look and place, and by the way, these 12 or these 10 electrodes that I'm putting onto somebody's chest, 4 of them are going onto the arms and legs. 1 on each arm, 1 on each leg. The remaining 6 we'll find go on the chest. From those 10 electrode placements, I can generate 12 different views. Lead 1 goes in this direction. So I'm looking at the heart from right to left. Lead 2 goes from right arm to left leg. Bless you. Lead 3 creates or completes the triangle by going in that direction. Now, you don't really need to know this for me for now, but if you'll notice there's polarity that exists, then you're always going from negative to positive, negative to positive, negative to positive. So the left arm can be positive or negative depending upon which it needs to be. Yeah. These are your limb leads, your standard leads. They form a triangle. You may have heard of Einthoven's triangle. You may not have. Einthoven was the guy who came up with this concept of measuring electrical current that's going through the heart by looking at leads placed external to on the skin. If this was my heart, in what general direction would you say it's going? Where does the impulse go as it's going through the heart? Can I say maybe along this direction? Going from the right atrium and the left side of the right atrium down through the heart. Since the left ventricle is a bigger mass, it's probably generating more of the pull. Which lead looks like that? Lead 2. Lead 2 is called the idiot's lead. If you know nothing else about EKGs, we look at lead 2 because it gives us the best picture, the best representation of what's going on. Lead 2. Idiot lead. That's my name. Because it represents what the heart is really doing. Limb leads. Lead 1, lead 2, lead 3. For right now, that's all I want you to know. I will tell you that Jeannie will want you to know lead 1 is negative to positive, lead 2 is negative to positive, lead 3 is dead. Right now, that's all I care about. 3 limb leads. 1, 2, and 3. The AV are kind of funky ones. The AV leads go from the center of that triangle. Remember I said I had lead 1, lead 2, lead 3. AV goes from the center of that triangle out to the right shoulder, AVR, out to the left shoulder, AVL, to the bottom, AVF, AV foot. So right, left, foot. 3 augmented voltage leads, AVR, AVL, AVF. You can tell me the names, I'm happy. Done. I'm looking at the heart from 3 different leads. What do you notice about AVR? Starts here, goes off to the right shoulder. What do you notice about that direction? It's exactly opposite of lead 2, isn't it? So how do you think the ECG would look? Upside down.
So does their go, so like in the heart's negative then? Does their go
Right, right, right. How it gets there, we don't want to know. But it's in essence a negative electrode. Lastly, thank God, instead of looking in the vertical plane, as both of these were, we're going to look in the horizontal plane. Imagine I took a big knife and cut right through the center of your chest. Now what I'm measuring are the chest leads, or precordial leads. And they're measuring coming across my thorax. Lead 1 is pointing this way, lead 2 is pointing that way, lead 3 is pointing that way, 4, 5, V6. It gives me a picture of what's happening inside that heart looking across its anterior surface. 6 precordial leads, named V1 through V6. Can I make the assumption this was not covered in A&P? Okay. Okay. Well, it's a little bit. 12 leads, 12 different ways to look at that PQRST. 3 of them are limb leads. 3 of them are augmented voltage leads. 6 of them are chest leads. Go ahead.
You, of the degree, do you want to know the...
Blah, 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 blah. Name. How many are there? 12 total.
I have a question real quick. When I see people doing TVs, they always have a tab on each leg.
Yeah.
Is that because the foot one? The augmented, the other one's on the foot?
Technically, yeah, you are exactly correct. One is also a ground that you need it to complete the circuit. It's a reference.
So do they actually put 13 on it?
No, they actually put on 10.
What?
1 on each limb, 6 across the chest.
Now you're throwing things.
There are, listen to me, Randy, there are 10 electrodes.
Okay.
From those 10 electrodes, we get 12 different pictures.
Oh, okay.
Because some of those electrodes do double duty.
Okay, I get it now. Sorry.
That's an excellent, that's always a source of confusion. Here's where the chest electrodes are placed. And if you can imagine it coming from the center of the chest out through those electrodes, that's basically what picture we're looking at. And ultimately, this is the way the EKG is set up. And you will get really good at reading these. Because to be honest with you, in a lot of institutions, we do these. I always have a problem with somebody who does a diagnostic test and doesn't know how to interpret the results. That scares me. You should know what a 12 lead looks like. It's not just the act of doing it. I want you to be able to interpret it. Okay. Can everybody see PQRST? But this one looks a little bit different than this one, which looks a whole lot different than that one. Even though it's exactly the same heart, it's looking at it from a different view. And each lead will give us a little bit different telling of what's going on. Okay? And I think we'll stop there. Just 'cause.